afternoon to you all. November month is considered as Pancreatic Cancer Awareness Month. On behalf of that, we are conducting a Facebook live session on chemotherapy, a key player for pancreatic cancer. Let me introduce myself. I am Dr. Chinmaya Pani. I am a medical oncologist at Apollo Hospital, Bhubaneswar. I have done my MBBS at VSS Medical College, Burla, MD at Cuttack, and my doctorate DM degree from Jipmer, Pondicherry. I have done 2-year residency at All India Institute, New Delhi also. So let us come from the basic that what is pancreatic cancer? Pancreatic cancer begins when the abnormal cells in the pancreas grows and divide out of the control and form a tumor. The malignant tumor is always called a cancer when the cells grows out of control and can spread to the other tissue and organ. The next question that what about the statistics of the pancreatic cancer? So coming to the point, pancreatic cancer is one of the cancer with a very low survival. From the survival is from 8 to 14%. There are 1257 cases diagnosed daily, and out of which 1180 cases died daily. The number is going to shoot up in 2025. The number will be 5,57,000. In 2012, pancreatic cancer was the seventh killer of all malignancy. But in 2030, it will be the second killer. So let us know what are the signs and symptoms of the pancreatic cancer. First is jaundice, dark urine and light stool, unintended weight loss, there is nausea, there is bloating, there is back pain and upper abdominal pain. Also, there may have the lower abdominal pain. There is loss of appetite and pain after the eating. So these are a very vague symptom complex. Apart from this, there is fatigue or generalized weakness, loss of appetite. There will be an episode of acute pancreatic attack. There may be a taste alteration and early fullness when eating. But another important part is new onset of diabetes after 50, worsening of diabetes on a patient who is on diabetic therapy, and if a diabetic patient is sudden heavy weight loss, then consider or evaluate as a form of pancreatic cancer. If we see what are the risk factors for the pancreatic cancer, first is the family history. The strong family history correlation, almost 10% of cases have a suggestive family history or a genetic problem. As the smokers increases, there is chances of increase in chance of pancreatic malignancy. So also heavy alcohol intake associated with. If you had a diabetes more than 5 years, you may have the high risk of pancreatic cancer. So also the obesity and history of pancreatitis has a high risk of pancreatic cancer. So let us discuss that what are the investigations you need to do to detect that whether it's a pancreatic cancer or not. The most important investigation is the CT scan, the contrast enhanced CT scan of the abdomen using a pancreatic protocol is a very specified investigation along with the CA 19.9. Biopsy usually we don't do unless we plan for giving neoadjuvant chemotherapy, and the biopsy should be done with endoscopic ultrasound based biopsy to be done. Otherwise, we directly go for surgery when it is localized. We consider after the diagnosis is done, then we have to evaluate what is exactly the stage of the disease. Stage 1 and stage 2 initially when the disease is confined to the pancreas. Stage 3 when the adjacent blood vessels are being involved, and stage 4 when the disease has been spread to the distant organs. If we see almost the patient who are 50% of patient initially presented with the advanced disease means stage 4. The stage 2B or stage 3 patients are almost about 15%, and the localized disease means when localized unresectable disease means when the advanced locally advanced disease is almost 25%, and the locally resectable disease means disease confined to the pancreas, the numbers are quite less, it's almost 10%. The problem is that most of the patients are in the advanced disease. So once we go ahead, once we get the diagnosis gets done, what should you do? The first and foremost important is you should always get a second opinion. Why the second opinion? Because you should get enough knowledge about how to get yourself being treated, and choose the healthcare team where you want to be treated, and learn about the various treatment options, know about the type of the cancer, know about your cancer staging, know where the tumor is located or it has spread or not, and ask the surgeon whether surgery is possible or not, and what is the options of treatment after the diagnosis. My question, an important question is there any chance to detect the disease early? Is there any chance of early detection? There is no established way to detect the disease early, because the pancreas is deeply seated and the symptoms are not always obvious, and there is no proven molecular or the biomarker clue to detect it early. Then once you know and detect the tumor, then you should know something about something called the tumor board. So when you diagnose pancreatic cancer, you should need input from the various subspecialty involved in the pancreatic malignancy, like pathologist, radiologist, oncologist, your oncosurgeon, your gastroenterologist, genetic counselor, dietitian, nutritionist, social worker, and also the nursing people. Then how the chemotherapy plays an important role. Let us brief something about the chemotherapy, then we'll speak something specific about the chemotherapy. The chemotherapy are a special group of the medication that has been given intravenously through the IV line. So these are designed to stop the cancer cell in their tract, preventing from growing, dividing and spreading to the other organs. The medications travels in the bloodstream and kills cancer cells throughout the body. No matter what is the stage of cancer you will have, pancreatic cancer you have, the chances are good that chemotherapy play a starring role in the treatment paradigm. It can be given before surgery, after surgery, and as a palliative intent when the disease has been spread as a multi-agent chemotherapy. But most important thing is after diagnosis you need to decide whether you are going to do the surgery or not. In surgery there are three possibilities, whether it is operable or it is not operable or it is a borderline. And the borderline depends upon the technicality. I'll speak later on, we'll discuss that things later on. The first thing is the deciding the resectability, whether you could able to take away the tumor or not. Whether after taking out the tumor there will be completely taken out a tumor or not, yes or no, or it is not resectable, not operable, or it is in borderline phase. But important thing is surgery is rarely curative, because it is a systemic disease. Though you are seeing the tumor in the pancreas, the tumor may be in anywhere else in the body. Even if it is a small tumor, only after taking the surgery there is high chances of recurrence. So the survival after the immediate resections is almost about 18 months. 70 to 80% patients died of the systemic disease rather than the local recurrences. Rather than the local, people died from the systemic disease. So, an adjuvant chemotherapy with radiotherapy failed to improve the survival, but the adjuvant chemotherapy has significantly improved the survival. And what chemotherapy to be given? There are a lot of controversy about it, but just to specify that there are various trial on that we can say that we can give. The point number one is there is something called fifo-Russell, whether no chemotherapy versus fifo-Russell, fifo-Russell is better. Then no chemotherapy versus gemcitabine, gemcitabine is better. Gemcitabine has equivalency than that of the fifo-Russell, and gemcitabine plus capecitabine is definitely better than capecitabine. And recently there is a data from modified FOLFIRINOX. Looks very complicated, but the doctor will tell you in detail what is modified FOLFIRINOX. It has the best survival advantage if it is given post-operatively. So the thing is that the post-operative chemotherapy to be given and it is better for the patient, those who are physically fit. And it has a definite improvement in the survival, both disease specific and also the overall survival. And if the patient is fit, modified FOLFIRINOX to be given. If the patient is unfit, then gemcitabine with capecitabine is a good alternative. But what is the disadvantage of giving chemotherapy post-operatively? Because people thought that post-surgery they are fine, so they are not willing, they don't receive the post-operative chemotherapy due to maybe age, post-operative complication, the deterioration of general health and late recovery after the surgery, and there may be very early disease reappearance after the surgery, and around 25% of cases has a very early recurrences. So then coming to the these are the group those who would able to do the surgery, but there are some group you can't do the surgery, you have to give chemotherapy before conducting the surgery. So these are something called the borderline tumors. How to know what is a borderline tumor? The borderline tumor are basically adjacent blood vessels are being involved. They have a large primary tumor. The tumor size is more than 3 cm. They have a large lymph node around the tumor. The patient is highly symptomatic. There is pain to the patient, and CA 19.9 levels are being elevated, and there is a comorbidity. You could not be able to do the surgery because of obesity, because of the cardiac issue, and the other problems are patient is apprehensive, or the doctor is apprehensive for unacceptable mortality, death rate, and late recovery, which could problem to the patient in the treatment paradigm. So does it change the therapy? Does it change the plan that in spite of going surgery followed by the chemotherapy, can you do the chemotherapy before the surgery and then you do the surgery? Answer is yes. That could be a true perspective of treating the patient, of giving chemotherapy before surgery and do the surgery later on. But the problem I told you, we need to have a tissue, we need to have the pathological diagnosis before going for the chemotherapy. For that reason, you need to do a endoscopic ultrasound and followed by the biopsy, or you may require a biliary stenting for reduction of the jaundice or the bilirubin. But if I can depict, there are lots of advantage of giving chemotherapy before surgery. That means that are immediately target the occult disease, the chemotherapy immediately target the occult disease, avoid treatment delay due to the logistics of the surgery or surgical outcome, the improve the patient's systemic treatment is early, and treatment compliance is early. There is definitely the less node, and there will be better surgical clearance, and there will be intraoperatively tumor spillage is less, and better chemo distributions to the organs you have resected. But there is lack of data when they analyze that chemotherapy before surgery and followed by two surgery upfront. So definitely the survival is better the people to whom chemotherapy given before surgery, and they have a better resectability rate. Resection rate is better, and in the resected specimen, absence of tumor may be high, and the nodal clearances are better and less aggressive. You have reduces the poor histological factors. Then what chemotherapy to be given? If you give before surgery, it is modified FOLFIRINOX. Again, what is the adequate duration? It is at least up to 6 cycles, definitely 6 months. But there is always apprehension that if the disease is progressed, then what could be the option after chemotherapy? If you could not do the surgery, then definitely chemoradiotherapy is a better alternative. Maybe SBRT may be the better alternative. If the disease is stable or it is partial response, but due to chemotherapy toxicity you could not able to operate, then also you have an options of giving stereotactic body radiotherapy. And if there is no benefit from the first line chemotherapy, then you can go for the second line chemotherapy, and definitely the disease outcome is bad. But how to know, how to early detect the disease for the surgeon? If radiologically the tumor size has been reduced more than 10%, CA 19.9 reduced more than 50%, and specifically the tumor is located at the tail, and there is no or decrease the venous involvement, and at that point of time you can go ahead with surgery as quickly as possible. So definitely primary resection with post-operative chemotherapy will be the standard approach for small tumor, but definitely FOLFIRINOX will be the best chosen if the patient is fit, and gemcitabine and capacitabine will the person to be given those who are unfit. And there is an evolving evidences that the chemotherapy to be given before conducting surgery, and that has a better prognostication and better survival, definitely specifically in the borderline cases. So I meant to say the stage 1 stage 2 disease where the goal of treatment is potentially curative, we tend to give more aggressive chemotherapy choices, and where the management is very crucial. So as I told you, what are the different adverse effects? The chemotherapy usually attacks the dividing cell, and whether they are healthy or they may be cancerous, and that means it may come with a significant side effect. As healthy cells divide rapidly, such as skin, hair, bone marrow, and the blood cell, the cells in the reproductive and digestive tract, they are the greatest risk of damage. So the side effects are the alteration in the taste, there is a fatigue, there is a diarrhea, there is hair loss, there will be skin changes, blood count, lowering of blood count, decreased appetite, vomiting, mouth ulcer, nail changes, sometimes numbness and tinglings in the hands and foot. And so it is always important to talk to doctor about any side effect that you are experiencing. Another important thing, because you are doing a surgery called the Whipple's, a very radical, a very big surgery, so you need to discuss with the dietitian about your plan of feeding. So the general advice is consume small, frequent, balanced meal, but not just snack, 6 to 8 per day to help to combat weight loss and tiredness. Avoid high-fat foods. Food you should contain the food which is of soluble fiber, like banana, like oat oats fiber, that will be better than that of the complex fiber. Avoid sugary foods and take out a portion of your carbohydrate. So increase low fat dairy, protein, beans, fish, seafood and poultry rather than the red meat. Keep yourself hydrated by drinking the beverages like water, juice, electrolyte replacement, and stay active. Do exercise 5 minutes, 10 minutes, 15 minutes of physical activity, 2 to 3 times a day can stimulate your appetite and promote emptying of the stomach and make you a healthy life. After everything is over, how you follow up, how you track the patient, whether the disease haven't come up or they came. So though there are limited evidences how to trace the patient, how to track the patient, but still the best recommendation is to have every follow up every 3 to 6 months up to 5 years up to 5 years. And there is no benefit of doing routine CA19.9. It is always the symptom, pain, weight loss, and reduction of appetite are the telltale sign of early diagnosis of pancreatic cancer recurrences. And CT scan plays a very important role in diagnosing early recurrences. So, with a very short span of time, I have elaborated a lots and lots regarding the deadly disease called the pancreatic cancer. Though there is not much significant changes in management or outcome for the last decade, and I think it's the only cancer where the survival has not been improved for last 10 years. But currently there are development of increase in the surgical skills from the surgeons, the chemotherapy and the genetic analysis like the association of BRCA1 and BRCA2, and then development of various new drugs like olaparib, and the role of the immunotherapy has a promising and upcoming role. And due to constraint of time, we could not discuss so many things, but still there is always a ray of hope at last. So thank you very much. Stay active, stay alive, and make yourself fit and stay safe.